First of all, I'd like to thank Dr. Christine Kim for taking the time to do this webinar for us. Dr. Kim is an Associate Director of Neuropsychology Training at the VA in Long Beach, California. And Dr. Kim received her PhD in clinical psychology from Boulder School of Psychology and completed an internship at the West LA VA at the Geropsychology track and completed a 2-year neuropsych postdoctoral fellowship at UCLA Department of Neurology and Semel Institute in the Neurology of Aging track. She was co-director of neuropsychology at the Loma Linda VA for 7 years before coming to the Long Beach VA 4 years ago, where she currently the Associate Director of Neuropsychology Training. Dr. Kim supervises all levels of neuropsychology training from practicum to postdoctoral fellowship, and she works in the neuropsychology clinic, conducting primarily outpatient neuropsychological evaluations for veterans across the adult lifespan with presentations including neurological conditions such as TBI and dementias, mood disorders, and substance use disorders. So without further ado, I'd like to pass it off to Dr. Christine Kim.
Thank you, Jacob, and thank you, everyone. I appreciate the invitation to talk. And I'm realizing also that today was internship match day, so I don't know how many of you out there were part of the match, but hopefully everyone got good news and are excited about their next year of training. So congratulations, everyone. It's quite a big feat that you guys have to go through. So I am going to share my screen. So let's see if we could do that. Okay. And can you guys let me know if you guys are seeing the correct display, or are you guys seeing the notes?
We're currently seeing the presenter view.
The presenter view? Okay, so I need to switch.
Yes.
There we go. Is that better?
Yes, it is.
Thank you, thank you. Okay. So, yeah, I'm going to talk about TBI in the VA, and I'm going to do that today by, instead of lecturing about, the topics of traumatic brain injury and veterans, I'm going to just present a couple neuropsych cases of veterans with TBI that I saw, and I'll kind of go through the case. You guys can kind of see kind of what we do in neuropsychology and what we do with assessment and how it can inform our treatment. As I'm going along, please, put in the chat box any questions that you may have, and I may pose questions like that may be rhetorical, so that you guys can kind of think about some things as we're going along. Obviously, with the number of people, it may be hard to kind of chime in, so I'll just answer my own questions, but it may be things food for thought for you guys. I'm also not sure how much exposure experience people have with neuropsychology, so forgive me. I assumed that people probably had little, so there may be some slides where I kind of show certain tests. So if those are all things that you guys are all very familiar with, I apologize for that, but just wanted to make sure that I was covering the bases. So without further ado, let's go into the cases. Okay, so the first case is of a 30-year-old right-handed Hispanic male with 12 years of education. Okay, he had come for a neuropsych testing because about 5 years ago he had experienced a TBI through an IED blast. In terms of like other injuries, he reported having lacerations on his chin and his eyebrows. He did have his helmet on, and he reported being dazed and confused for about 10 minutes after the blast, but denied any loss of consciousness or post-traumatic amnesia. Okay, so first thing I will ask is, based on the demographic information that we have, 30-year-old right-handed Hispanic male with 12 years of education, ballpark, if we had to guesstimate his premorbid abilities, premorbid IQ, kind of what would you guess? Okay. And we know that like a lot of times education and level of education and like IQ can be correlated. So based on the fact this is a young guy, 12 years of education, my guess is going to be he's probably around the average range. So I'm going to keep that in mind when I go to do the neuropsych data and kind of thinking of what my expectations of him are and kind of where I expect his scores to be. Okay. Second question I have is, given the information about his injury, what level of TBI, what severity TBI would you say he had? He was dazed and confused for 10 minutes, no loss of consciousness, no PTA.
Seems mild.
Yeah, would be mild, right? And that's one of those things to know. The things I would say about this is that this is kind of the way that the DoD and the VA rate the severity of injury, right? So one of the things that I want to highlight is it is possible to have a TBI without having any loss of consciousness, without having any post-traumatic amnesia, right? It goes from 0, right? 0 to 30 minutes, 0 to 1 day for the mild range, right? And someone who describes kind of that initial experience of being like dazed and confused can fall under that altered consciousness category, so anything under 24 hours would fall under the mild range. The other thing that can happen, though, that's a caveat to this, is when someone is reporting that they're dazed and confused, it could also be that it could just be shock, right? Like they just they just went through something pretty extraordinary, right? Having an IED, explode enough to, like jar them, right? And it's going to be pretty shocking, right? So that could be adrenaline and that can be shock that can cause some of the being dazed and confused as well, right? So those are some of the things that can be a little bit difficult to kind of tease apart when we're doing these evaluations with our patients. But for the sake of our case, we're going to say that that would qualify for the altered consciousness. Okay, so yeah, so it would fall under the mild range. Okay. So he reported that he was having short-term memory problems and concentration difficulties, and a lot of like mood issues. He started having like anxiety and just much more irritable and feeling out of it. Sleep problems, dizziness and balance issues, tinnitus, headaches, blurred vision, and sensitivity to light and noise. Okay. So, based on all this information, based on his cognitive complaints, based on his mood complaints, based on the level of head injury, based on the fact that this was 5 years ago, what kind of an evaluation would you do? And what we know is that when it comes to mild TBIs and concussions, for the data right now says that regardless of the mechanism of injury, whether it's a sports concussion, whether it's a blast injury, whether it's a car accident, if it's a mild TBI, your cognitive and actually pretty much all of your symptoms should recover within a week, at most 3 months. Okay. So someone who had a mild TBI 5 years ago, I'm going to start, because I know his cognitive functioning should have recovered back to baseline if it was solely based on the TBI. I'm going to start with a briefer battery. Okay, so that's something to keep in mind. And also, like just to make sure we're on the same page, this is kind of what I use in terms of my ratings when I'm looking at normative scores. And for a guy who is I'm going to presume is about probably in the average premorbid abilities. Anything that I would say anything in the like low average to and above is something that I would consider within expectation and within normal limits. Okay, so as long as it's low average or above, I'm not gonna be too worried about it. Okay, so that's to keep that in mind as we go through the data. Okay, so The first thing we're going to look at is his attention and processing speed. Okay. So I'm assuming you guys are familiar with the digit span, waist digit span. Just in case you guys are not familiar with the trail making test, it's, you know, a test where you give them, this would be example, a piece of paper that has a bunch of numbers, and they have to draw a line from one in order from lowest to highest as fast as they can without making mistakes. Okay. So looking at his scores, you know, and keeping in mind that scores that are probably 9th, 10th, you know, low average and a percentile and above are considered, you know, normal within like expectation for him. When I'm looking at his scores, would you say there's anything to be concerned? Probably not, right? We're looking at scores that are 25th, 27th percentile. So those are in the average range for a guy that I'm assuming has probably about average of premorbid abilities. It's probably right as I expect, right? We don't always, and again, I don't want to only look at like normative scores and percentiles. So I also look at raw scores too. I like looking at the span lengths of when I'm looking at digit span. So what would be the expected forward span length of someone, like someone without any difficulties, like an average span length? Okay. It's going to be phone numbers, right? So 7 plus or minus 2. Right, so that's kind of the span length of an average person about how many units of information they can hold, right? So it's going to be about 7 plus or minus 2. So that means that forward span length of 6 is within expectation. And then in terms of the backward span length, I expect it to be about 2 with about 2 lower within 2 of their forward span. So his forward span was 6. That means a backward span of 4 is within expectation for this guy. So I'm not super worried about that either. Sequencing span length again goes up again. You know, I see this often, you know, anecdotally, I see this a lot. I think it's partly because, you know, putting numbers in order whether is something we kind of do a lot, you know, in school, in elementary school, we do that, put numbers in order. So I think it's a learned task, a more familiar task than backward span. We're not really used to like saying numbers backwards, right? That's not really something we really practice. So I think that's why we tend to see the backward span being a little bit lower than the sequencing span. Okay. And his trail making test looks fine. So I'm not worried about his attention or his processing speed. Right? Okay. Now looking at his language and visual spatial skills, NAB naming is a test where you show them, these aren't the actual, this is actually the MOCA, but you show them pictures of objects and they have to tell you the name, right? If they don't get it correctly, you can give them semantic cues. So you would say like it's a type of animal, or you can give them phonemic cues where you can say the word starts with the sound rye, right? So you can kind of give them those are the cues. Okay. COAT FAS in animals is a verbal fluency test where we are going to give them letters or a category like animals and tell as many different words as they can think of that begin with that letter or that fall within that category. Okay, so these are language tests. One's a verbal fluency test, one's a confrontation naming test. And when I'm looking at his scores, any concerns, anything outside of expectation? Not really, right? They're low average to average scores, right? 24th, 38 percentile. We're doing good. The NAB naming, he got 29 out of 31 without any cues or prompts, so he's doing okay. So we're looking good. His visual spatial, I gave him the BVMT copy. So the BVMT is actually a visual learning and memory test, but they have an option where, again, this is kind of just a sample, where you lay a page that has 6 geometric shapes in front of them and just have them copy it, okay? And he was able to you get 12 points total for that task, and he was able to get 12 out of 12, so we're doing okay. Okay. So let's look at verbal learning and memory. So remember, memory was one of the areas that he complained about that he's having difficulty with. And this is the CVLT. This is the short form. So it's going to be 9 words instead of 16. It doesn't have interference trial, things like that. But when we're looking, if we kind of just take a quick sweep and look at the scores, again, pretty much all within normal limits, right? 16th through to 69th percentile, all within expectation. If we look at trial 1, I like to look at trial 1, the raw score of trial 1, and compare it to the digit span forward and see if there's any differences. And we see that it's kind of exactly the same for him, right? He had a trial 1, got 6 words, similar to the forward digit span. He got 6, his span was 6, right? So he's pretty consistent. That's good. And whatever he got up to 8 words, 8 of the 9 words, and he was able to retain it after delays, right? Whether short delay or long delay, he was able to recall all those words. Recognition, during recognition, he was able to recall it, and forced choice, which is kind of like multiple choice, he was able to get all 9. Okay, so he's doing good. His memory is actually doing pretty well. I talked about the BVMT, which is like a verbal learning and memory test. Again, you showed, so this one, what you do is you show them that page with the 6 designs on them, show it to them, take it away, have them draw it from memory. You do it 3 times, so there's a learning aspect of it. And then after 25 minutes, you ask them to draw it from memory. Okay. And again, it's going to be out of 12 points total. And you see that he's able to learn, right, over trial. So he got all 12 by the end of the 3 trials, and he remembered all the details, got full credit after the delay as well, and recognition, obviously he did fine, right? So I'm not worried about his visual memory or his verbal memory. Okay. Now looking at executive functioning, we gave the second part of the trail making test, which is going to be Trails B, which is in this portion of it. This is a Japanese version of it, but there's a page that has numbers and letters, and you're supposed to alternate in order. So for us, it would be 1A, 2B, 3C, and you have them draw a line as quickly as they can without making any mistakes. And he was able to do that task solidly within 54 seconds, which is in the 62nd percentile, didn't make any errors. So we're doing good. And the verbal fluency test, the FAS in animals, again, has an executive component to it because there's an aspect of being able to retrieve information quickly. And especially with FAS, there's a lot of rules and kind of parameters to it. So there's like a rule following aspect of it too. So there's a little bit of executive. So if we put that in, we can consider that to have a little bit of executive functioning as well. And again, we said before that they're solid, right? So his executive functioning looks good as well. Okay. And then we gave him some mood measures. We gave him the Beck depression and anxiety, and also the military PTSD checklist. And what we find is he scored in the severe range on the BDI, the moderate range for the BAI, and pretty high. He hit the cutoff for the PTSD PTSD checklist. Okay. So given all that, what would you say his diagnosis is? Would you diagnose him with a neurocognitive disorder? Okay. So we would not, right? None of his scores were in the impaired range, right? None of them were lower than expected, right? They were all solidly in the average, or some scores in the low average range, but they were all solidly in the average and high average range, right? So he would not meet criteria for a neurocognitive disorder. I will say that, I always start with a screen with my mild TBI folks. But if anything is out of the ordinary, then I will expand, and do a more lengthy battery. But with him, I didn't have to because there was not, right? Does that mean he didn't have a TBI? Not necessarily, right? TBI is an event right, is not necessarily a disorder, right? So just because he's recovered from the symptoms of his TBI from an objectively speaking from a neurocognitive standpoint doesn't mean he didn't have a TBI 5 years ago, right? So we can still say he had a TBI, right? And my guess is based on his scores that he probably would meet criteria for PTSD as well as depression, right? Um, and it's very common when we have our PTSD folks, especially when the PTSD index trauma is also the event that caused the TBI, for them to have a lot of somatic symptoms along with that too. The sensitivity to light and noise, having the insomnia, the blurred vision, things like that is actually pretty common. Okay. So that's my guess, is that we're probably looking at a guy who had a mild TBI, but the symptoms that he's continuing to experience is probably due to the mood conditions, the PTSD and the depression, and not from some sort of lasting neurocognitive effects. Okay. So what do we do with that, right? So what we do with that is, this is when the feedback comes into play, right? This is when we put on our clinical therapy hats, and we kind of explain. We do a lot of psychoeducation, and we provide some treatment recommendations, right? So the best, most effective treatment for for concussions and the prevention of post-concussive symptoms is preventative, is to provide psychoeducation pretty close to the time of the event, right? So after the TBI. I wish we did this more. I wish our providers, people that are actually on the field and those who see these folks like right after injury would provide the psychoeducation, but I don't think it's always on top of the list, especially if you're in combat, right? It's not necessarily something they're going to do. But providing education to those who've had a concussion or a mild TBI about what the expected recovery rate is, that you're going to be fine, you're going to recover 100%, there's not going to be any lasting damage, actually is really, really effective in preventing lasting cognitive sequelae. Okay, so that's one of the things that we want to do, and one of the reasons why I like doing these kind of lectures, to tell people outside of the neuropsych world, outside of just the TBI world, that this is the case. And if you have a patient, if you have a client who has had a mild TBI, have this be part of the treatment to provide that education in case someone else hasn't, right? And what we found, what the research has found, is that treating the mood symptoms will actually improve the cognitive symptoms as well, right? So doing the evidence-based therapies for depression, trauma-focused therapies for people, we have a lot of our folks who've had a mild TBI have also meet criteria for PTSD, and the rate of PTSD goes up the more serious the TBI is. So if the TBI did include a loss of consciousness, then the percentage of those folks who also have PTSD goes up. Which makes sense, right? The more serious it is, the more life-threatening the experience is, right? So that makes sense. And doing things like CBTI to treat the insomnia. So those are the recommendations that I will have. Okay. One of the things that we adopted at our VA, which we're actually pretty excited about, is something called Smart CPT. So this was developed by the San Diego VA, and it's a hybrid of CogSmart. So it's like Dr. Elizabeth Palmley down at San Diego VA who created CogSmart, and she kind of integrated it with cognitive processing therapy. So it's like for PTSD, right? So it's this hybrid Smart CPT that she developed, her and a bunch of people down in San Diego developed. And what they found was, when they did the evidence-based research on this, was that doing just CPT without any cog rehab, so just only doing the trauma-focused therapy, not only improve the PTSD symptoms, but they actually improve the cognitive symptoms as well. And actually their scores improved on significantly improved on neuropsych testing, right? So that tells us, right, like just doing the CPT, just even doing the trauma focused therapy will improve their cognitive performance and their neuropsych performance. What they found was that if you combine it with the Cog Smart, with some of the Cog rehab, then their cognitive abilities and their cognitive neuropsych scores goes up even more. Okay, so it's a great a therapy that they developed. They gave us permission to adapt it into a group format, so we're doing it at a group format at our VA, and we've had a lot of success with it. So it's something. So this is something that we would do with our patients, right? Who are have a lot of, like a lot of our TBI folks are going to have PTSD, and so they have cognitive complaints, and sometimes the PTSD clinic is like, well, then you have to go to the TBI clinic, and the TBI clinic, well, you have to go to the PTSD clinic. So it's kind of this, like, where these folks fit, and we kind of found this beautiful treatment that seems to be working. So that is those are kind of the treatments that I would recommend for someone with PTSD. Someone with a concussion and post-concussive symptoms. Okay, and I like the CPT because it also talks about, like things about how if you've had PTSD for a long time, it becomes kind of part of your identity, right? And who you are, and so there's another element of it that you need to overcome in order to kind of treat the PTSD. And I hear that a lot for people who have post-concussive symptoms too, right? For some of these folks, they've had a TBI and have felt debilitated by their TBI or what they attributed to their TBI for a very long time. And so being someone who has a traumatic brain injury has become part of their identity, right? So that's also something that has to be kind of like discussed and talked about in treatment. And I think because they have that similarity with the trauma focused therapy, I think it works really well. Okay. So that's the first case. Any questions before I move on to the second case?
I have a question for you, Dr. Kim.
Yeah.
Is it common for like this patient, patients coming in with that level of depression and PTSD to kind of come in with these subjective cognitive complaints, but it not show up in the neurocognitive testing?
It's very common. It's very common. If there's a lot, if their PTSD and depression is really debilitating, we can see it on our testing. There's a reason why, especially with our older folks, we have referrals asking if this is pseudodementia, right? And pseudodementia is kind of like thing like, are they looking like dementia because they're so depressed? So you actually can see it on cognitive testing. You can sometimes, but a lot of times we don't. Yeah. That's a good question. Yeah. Yeah, we also know with things like PTSD, especially if it's chronic PTSD, and this comes a lot out of like the child trauma literature, is that it can actually start affecting brain structures, right? There can be the hippocampi can be a little smaller than compared to others who don't have chronic PTSD. So it can start affecting brain structure too, especially if this is something that's been very, very chronic. And if that happens, we're going to see that in our scores too. Any other questions, or should I move on to the next one? Okay, I'm going to move on to the next one.
I think we can move on.
Oh, perfect. Thanks, Jacob. Okay, so the next case is a 55-year-old right-handed white male with 12 years of education. He had a couple events actually. He had an acquired brain injury about 6 years ago where he actually drowned through a drowning. He had to be intubated, about 5 days of loss of consciousness, and after recovering, about 5 weeks after recovery, he had 2 to 3 seizures. Okay. And then a year before I saw him, he had another accident where he fell down 15 flights of stairs. And he actually was in a coma for about 10 or 11 days, and actually had a subdural hematoma and a subarachnoid hemorrhage, and required, and actually had a craniotomy to kind of to relieve some of the hemorrhaging that had happened. Okay. So this guy, what level of TBI would you say this gentleman had? Right. Based on this, he would meet criteria for for severe, right? Loss of consciousness greater than a day would be um, severe, right? And those who've had severe TBIs, their risk of developing seizures or having seizures and actually developing epilepsy is actually significantly higher too. So that's one of the things that we have to watch out for. And there's some neurologists, if the TBI is significant enough, there's some neurologists who will actually give them anti-seizure medications kind of prophylactically too, for at least for a little bit while their brains are healing. So that's something to keep in mind. Okay. And so he had a subdural hematoma and a subarachnoid hemorrhage. So what does that mean? So we are talking about blood that was pooling within the meninges of the brain, right? And so it's just, the name will tell you kind of where it was. So a subdural hematoma means that there was blood below the dura mater, and a subarachnoid hemorrhage means that there was a blood beneath the arachnoid matter. Okay, so those knowing where the blood is going to help you kind of figure out what to expect on imaging, what to expect on testing, right? So if you have a subdural hematoma, because it's following like the dura mater, you're going to get kind of this convexity, this concave pooling of blood that you'll see kind of in A and B. Can you guys, I don't know if you guys can see, I'm assuming you guys can see my mouse, right? My cursor. So this is going to be, it's going to look like this, right? Some kind of like a kind of a lens, right? Crescent shape. Subarachnoid hemorrhage, because the arachnoid matter kind of follows the contours of the brain. That means the blood is also going to pool kind of following the contours of the brain too. So on imaging like a CT, you're going to see a subdural hematoma. Again, you're going to see that convexity right here, right? And a subarachnoid hemorrhage, because it follows the contours of the brain, it's going to be much more, it can often look like a starfish or something like that, right? Okay. So, so some of the things he complained about, he was having bilateral tremors on both hands, right? So, and dizziness, he was still falling, headaches, clumsiness, reduced hearing. He was having a lot of cognitive difficulties, both short-term and long-term memory difficulties. He was a plumber by trade, and they were saying that he actually couldn't remember how to fix things. You know, couldn't actually do his plumbing job anymore, and actually had to stop working after his second head injury. Slowed processing speed, attention difficulties, language difficulties, including spelling and stuttering difficulties. Said that he kind of doesn't really do anything. All he does is kind of sit in front of the TV and just watches the same TV shows over and over again. That's kind of all he does. Said that he's kind of had some confusion episodes where he would like leave to go to work when he wasn't working anymore, right? The wife said that he had a episode where he had made coffee and then came into the bedroom and poured it on the bed, or he would kind of get confused and have take out the trash at midnight. So he would wake up and go take out the trash at midnight. So there's some confusion episodes as well. Okay. He has a history of bipolar disorder and anxiety and depression. He said that on the day that I saw him, that he was feeling fine, but that that he did have a recent episode of depression with some anger and low energy and decreased appetite, and that since the second head injury, that he has been more anxious and a lot more easy to anger as well. Okay. Let's see. So he had a MRI, right, that showed the craniotomy in the right frontal temporal parietal area, right, and some remnants of the subdural hematoma in the right hemisphere, right, and they didn't show any new brain injuries, no new blood, anything like that. They did find a little bit of T2 hyperintensities in the peripheral aspect of the right temporal lobe that they think might be due to the actual brain injury, like the actual contusion, right? So he actually hit his head. But otherwise, they didn't find anything else, any new changes or anything like that, right? No atrophy, the ventricles all look normal, things like that, okay? So I'm going to show you a couple brain images. They are not of this guy, but just to highlight kind of like what it would look like. So something like a right. So, you know, in radiology, left is right, right is left, right? So this would be considered a right kind of subdural hematoma, right? Because again, you're getting that crescent shape. And hyperintensities, literally, they kind of look bright. They're like bright spots on imaging, and you know, this lateral, a peripheral aspect, and of the temporal lobes on the right side. Again, okay? So given his history, given the brain scans that say he had the right subdural hematoma, you know, and a little bit of right temporal hyperintensities, kind of what are we expecting in terms of his testing, his neuropsych testing? So because all of his injuries are, this guy has both, but because his injuries are on the right hemisphere, I would expect that tests that are testing cognitive abilities that are on the that are associated with the right hemisphere are going to be the things that I notice on testing versus the things that I expect to be associated with the right hemisphere or with the left hemisphere. Okay. Another thing is, so he had, so that was the second injury he had, right? But the first injury he had was an anoxic brain injury, right? He drowned, right? He drowned, had to be intubated, right? So that's an anoxic brain injury. So what part of the brain is affected by an anoxic brain injury? Okay. So I would expect that to be, you know, it's going to look a little like the white matter, right? So there's going to be some white matter changes, some frontal lobe impacts on frontal lobes, and also the hippocampi, the temporal lobes, the hippocampi really like oxygen, and so I expect those to also might be affected as well. Okay, so those are kind of the hypotheses that I'm going to have as I'm going into testing, and because there is lots of evidence and historical evidence and neuroimaging that shows that he's had some pretty significant injuries, I am going to do a more comprehensive test, a comprehensive battery, right? Okay. Sorry, let me get to, there we go. So looking at the digit span, okay, what are we noticing? We're noticing that if we're looking at his normative scores, right, he is, for his forward and backwards, he's actually doing pretty well, right? Solidly in the average to high average range, right? But his sequencing dropped significantly, right? And so that could be for a few reasons. One, it could be that he forgot the task and started doing digits backward, right? And so he just didn't get any scores. It could be that he just kind of couldn't sustain attention, and so by the third task he kind of lost it and kind of couldn't keep track of what he was supposed to do, right? So those, it can be a couple things like that. I want to look at the span length like I like to do. So his forward span length is a 7. So solidly right where we expect, right? Because we want 7 plus or minus 2, right? And we want his backward span length to be about within 2 of his forward, right? So I'm seeing that his span length, backward span length is a 4, right? So that tells me, even though that's solidly in the average range, that actually might be a little lower for him than I would want, maybe, right? So now I'm hypothesis testing, right? So backward span. What's the difference between forward span and backward span? Backward span is measuring working memory, right? And working memory, I conceptualize to be a little bit more in the frontal lobes, a little bit more executive functioning. So that's part of what I'm thinking. Okay, maybe we're looking at maybe some weaknesses in executive functioning, maybe some frontal system. So I'm going to keep that in mind as I go through the rest of the data to see if I can test that hypothesis. Okay. Let's go into processing speed. We did the Trails A like before, and I also did the DCAF's color word interference test. So in case you guys don't know, the DCAF's color word is the first 2 trials is I'm going to give them something like what looks like on the left, where I'm going to give a bunch of words and I say read that as quickly as you can, and then I'm giving them some color blocks and say name those colors as quickly as you can. Okay. So why am I seeing this discrepancy between the Trails A and the color word? They're both processing speed tests, right? So if his processing speed is good or bad, why aren't they both good or why aren't they both bad, right? So one of the things, good or bad, one of the things about neuropsych is that our tests aren't super specific, right? Which is also why some of our battery, our testing is kind of long too, right? So we kind of just have to see like what's the difference between Trails A and the color word interference test, right? One of the thing is that Trails A has a motor component, right? Like I actually have them like draw the lines, and with color word, I don't. They're just having to read it, right? And remember, this is a guy who has the bilateral tremors, right? So it could be that the tremors are impacting his score, right? So there's something to keep in mind. Right? Okay, and we'll keep going. And when I did a motor test, right, that kind of showed too, right? I gave him the groove pegboard, which is using just one hand each. They have to put some pegs into different oriented holes, and you do it with your dominant hand and the right hand. And we find that, like he's a bilateral tremors, he's having trouble with both hands, right? And I gave him the BDI, and he, like similar to what he reported, not having a ton of symptoms, right? Okay. Okay, going into language, gave the BNT is like a confrontation naming test where I show him a bunch of objects and he and tell me the name. I also gave him the FAS in animals. I also gave him the BVMT like we did before. I also included the block design from the WAIS, and I also gave him the Rayo copy, which is I gave him a complex figure like this, and I gave him a blank piece of paper and make him copy it. Okay. So what are we seeing? Okay. We're seeing that, his language scores are pretty solid, right? They're all, the BNT is out of 60, so he got 58 out of 60, 60 of the items. Beautiful. His FAS in animals, beautiful. He's not doing terribly. But his visual spatial tests, if I'm comparing his language scores from his visual spatial scores, they're relatively lower, right? The BVMT copy, he did okay, but again, it's also a lot simpler task than the Rayo copy or the block design, right? So I'm seeing this discrepancy between language and visual spatial, right? And when I'm looking back at his imaging, this makes sense, right? Because language tends to lateralize left, and our visual spatial skills tend to lateralize right, right? And I'm just realizing I'm using the wrong hands when I'm showing it. So if you guys can see me, I'm doing it the wrong way. So again, seems consistent with the imaging, right? So this is this is as expected. I'm seeing some of that lateralization of right versus left hemisphere tests, right? Scores, performances. Okay, looking at his verbal memory, I gave the WIMS logical memory, and also the CVLT, the standard form, which is out of 16 words. Okay, and what I'm seeing is that he did not do well with the logical memory. He initially didn't do well with the CVLT, but he eventually learned that, like, if you look at the total, you see that there is a learning slope there, right? And whatever he learned, he kind of retained, right? So his scores, they're not great, right? I would kind of want these to be a little bit higher, given that some of his other scores are in the high average range, right? But they're kind of okay, right? Logical memory, he didn't do well, and it could be because, like we said, like if you look at these, it kind of takes him. Repetition helps him, right? But with logical memory, it's just kind of a one-shot deal, right? You hear the story one time and you have to remember it, and then 30 minutes later you have to remember it again, right? So there's not a lot of like practice. There's no repetition of the stories, right? But with the CVLT there is. So this is a guy who benefits from repetition, and I'm going to say that in my recommendations to him too, right? When I'm saying, like, what are the things you could do to compensate for some memory difficulties? Repetition, learning, practice, right? So those are the things I'm gonna say. Okay. Compared to his visual memory scores. So the Rayo is like that complicated copy that I had him copy, and then I'm going to surprise him and tell him to draw it from memory 3 minutes and 30 minutes later, right? He, compared to his like CVLT scores, compared to his memories, visual memory scores, right? His visual memory is worse than his verbal memory. Okay, and again, that's kind of consistent with the imaging, right? His right hemisphere stuff, which is visual, right, is worse than his language or verbal scores, right? Okay, let's look at his executive functioning. We did the Trails B. The DCAV's design fluency is where there's 3 sections where I'm going to have them draw, have him draw designs. First trial is just with a bunch of filled dots. The second one is ignoring the filled dots and only using the empty dots. And then the third trial is he has to switch from empty filled, empty filled, empty filled. Okay. So that's what he's having to do with that. And then the DCAF's color word, the executive functioning tests are where he has to ignore the reading of the word and tell me the ink color, right? So you're trying to inhibit an overlearned task, which is the reading, and tell me the color of the ink, right? So this is it's really pulling for that inhibition, which is part of the executive functioning, okay? And then the fourth trial is he has to switch. Sometimes he has to read the word, sometimes he has to tell me the ink color. So he's got to switch, okay? So again, I'm kind of seeing some of that discrepancy, right? Where the design fluency is a little bit more verbal, is more visual, right? You're actually doing designs over color word where it's like verbal, right? And I'm seeing that to be a little bit higher, right? So I'm seeing this verbal versus visual discrepancy. But another thing I'm going to say is, well, maybe it's because the design fluency again requires a motor component, right? Maybe it's just that. And that could be definitely part of it, right? Because all the tests that require motor component, he's doing slow on, right? So I'm going to give him a few more tests. Right. We did the co-op, the FAS in animals, and I also gave him the Wisconsin card sorting test, which is a test where it's a trial and error kind of a guessing game or problem solving game where he has to match the card that's down here to one of the key cards up here. But I don't tell him the rules. I don't tell him how he's supposed to match the cards. And once he starts figuring it out, I'm going to switch the rules without telling him. So he's going to have to figure it out again. Okay. So what I see is that he couldn't do any categories. right? In fact, he perseverated, meaning that he stuck to whether if it was whether if he thought that it was based on color, that's all he did. Color, 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 color. No matter how many times I told him that was wrong, he stuck with color, color, color. So he couldn't shift, right? He was kind of perseverating, and so he never got any categories. He never got any of the categories complete, right? So I am seeing that even without the motor component, that his verbal scores are, again, tests are better than his visual tests. Okay, so I'm seeing that laterality again too. Okay, so what do I diagnose him with? Can I diagnose him with a neurocognitive disorder? Yes, right? And now we have an option of mild or major. What's the difference between mild neurocognitive disorder and major neurocognitive disorder? Okay. So the difference between the two is basically whether it's causing functional impairment, right? So any changes in your ADLs, your IADLs, things like that. And what do we know about him? He couldn't work anymore after his head injury, so he stopped working. So we got that functional, and maybe even some of the IADLs when he is making coffee and pouring it on his bed, right? So so he's definitely has some functional impairment. So this is a guy who I would say meets criteria for major neurocognitive disorder. Definitely TBI, right? There's a possibility that the bipolar and depression are also impacting some of this. Like bipolar can affect the frontal lobe, so it can affect some executive function tasks, especially things like response inhibition and kind of switching tasks. Depression can also affect memory and slow processing speed and executive functioning, so it could be those as well. But he wasn't having significant symptoms when we saw him, and the tests clearly showed this laterality that was consistent with what I expected based on his injuries, right? So this is a guy who had a major neurocognitive disorder due to a traumatic brain injury, okay? And some of the slow processing speed that we saw, I think part of it was the motor, right? And I think some of it was probably some of the anoxic brain injury as well, right? That can cause some slow processing speed too, okay? So what is the prognosis, especially after like a moderate or severe head injury, particularly a severe head injury? What's the expected recovery? What's the prognosis? Okay. So barring other complications, right, our brains tend to heal, and we see the most significant recovery within the first 6 months, but we can continue to see recovery up to 18 and 24 months, right? So this is a guy that I saw a year after his second injury, right? So it's quite possible that in the next year, he may continue to recover and to continue to see improvement, right? Especially if he is, doing the rehab that he needs to do, and he's managing his bipolar and depression symptoms really well, right? So those are the things that I would recommend, for someone with this level of injury, as well as provide recommendations and resources for the family. Right, so this is going to be there. We're going to provide a lot of caregiver support. The VA has a caregiver support program, whether it's for things like memory disorders and dementia, or whether it's for like significant a mental illness. We have caregiver support programs, which we provide. So those are the things that I would give, as well as cognitive compensatory strategies. Like, his memory seems to do better with verbal information versus visuals. So provide information to him in a visual format versus a verbal format versus visual format, and provide repetition, remind him, give him cues. Those are the things I would recommend for someone like him. Yeah, and say his simple attention is okay, right? So use that. And so that means that he's not going to be able to pay attention for a super long period of time, but he may be able to pay attention for short periods of time and take breaks, right? Give him plenty of breaks. Don't let him fatigue out, things like that.
Dr. Kim, we had a
Yes.
question if this individual would be someone that would benefit from the CogSmart program.
You know, possibly. It's I tend to, and I don't know if there's others out there who use CogSmart frequently. I typically conceptualize CogSmart as someone to use for someone maybe in like the mild like cognitive impair, like MCI range, like mild neurocognitive range, or someone who have like post-concussive symptoms and things like that. But I think but CogSmart also provides like compensatory strategies, right? So I think those are things that he could implement and probably would benefit from as well. You know, so I don't know if there's others out there who have used it for people with more severe brain injuries that would say yay or nay. Other questions?
I had a clarification question for you.
Mhm.
Were the seizures, do you know if they're focal or generalized seizures?
Oh, good question. If I am remembering correctly, I believe they were focal. He had an EEG. He did have an EEG, and I know they found, they did find like seizure foci there, and so they were focal. Yeah. Yeah, but I think they put him on medications afterwards. So so he had 2 to 3, but he hasn't had any since, and he definitely didn't have any recently when I saw him.
Does anyone have any more questions for Dr. Kim?
And I wasn't sure if there were like other questions about like TBIs that weren't covered, you know, based on the cases or anything like that.
We had a question if you can speak to why his motor difficulties were not localized.
You know, it could be because part of it could be the anoxic brain injury, right? So because the drowning, when there's the drowning and the anoxic brain injury, it doesn't necessarily like localize to one area, right? The whole brain is deprived of oxygen, and it's the white matter tracts that can kind of be affected by that. So it could be slowed. It could be slowed before for that reason too. I will say that on his let me see if I go back, his groove pegboard scores, even though they were both, oops, where am I? There we go. Even though both were impaired, right, or both were like in the 3rd percentile, T scores were the same. You know, I tend to want to see the dominant hand to be a little bit faster than a non-dominant hand, right? So, you know, that being said, so the groove pegboard is looking at fine motor skills, right? Because you're using your fingers to kind of manipulate the pegs, and so and so it's possible. I guess no, because then that would make it left because he's right-handed. Because I was going to say that maybe that's why his dominant hand is not as fast as I want it to be, but that would mean right hand would mean left hemisphere. So yeah, not really. I would say both bad. If anything, I would say I would expect his non-dominant hand to be worse. Yeah. Yeah. So, and then the other thing that I would say is that when we are talking about like the hematomas and the subdural hematoma that he had, you know, it's staying within the dura mater, right? So what that means is that it's actually like the blood is not actually touching brain tissue, right? So that's another thing about that too. It's like it's encased within the dura mater, which is why you see kind of that crescent shape, right? So that means that a lot of what's going to be impacted is going to be by the pressure or any displacement that happens because of the bleeding, right? So so it could be possibly that some of the slowing and some of the motor symptoms are impacted by just the pressure both ways, that's just generally put on the brain, or it could be the anoxic brain injury too. That's a good question. Sometimes it happens, right? Sometimes it's our tests are not super clean. It doesn't always come out exactly as I wish they would, as I would want them to. So that happens sometimes too. Yeah.
All right, it looks like we have one more question about some of the resulting behavioral changes from TBI. And they're asking, is there a potential for recovery, like cognitive functioning, or are these behavioral changes seen as potentially permanent changes due to the brain damage?
It can, right? So it depends. Everyone is going to recover differently, and how much they recover is going to be different for everyone. And things like premorbid abilities, cognitive reserve, how much social support you have, how much significant psych history, premorbid psych history you have, substance, substance use, all of these things impact prognosis, right? So how much recovery you're going to have within that 18 to 24 months is going to be variable for everyone. You can have like behavioral and social, social changes after a particularly severe head injury, like some personality changes and things like that. And they can recover, like they can recover. There may be like subtle, like changes and signs that that can still be there, that most people may not even notice, unless you tell them, or you tell a neuropsychologist that like I actually had a severe brain injury, and then they could be like, oh yeah, that makes sense. Those subtle things that I noticed, that makes sense, but it may not, right? The brain is an amazing thing, right? As sensitive, as delicate as it is, it's also amazingly resilient, right? I had classmates in grad school who had, a couple of them who had severe head injuries with craniotomies, and they completed a doctoral clinical psychology program and are amazing psychologists, right? So our brain is an amazing thing, right? And if you met them, you would not know, no personality or behavioral things that would make you say that they that they had a brain injury. From a cognitive standpoint, they definitely don't, right? And like you have to have a lot of like interpersonal skills to be a therapist, right? And they're good, and they're amazing therapists. So so you can recover.
Thank you. And we have another question about asking if you can share thoughts about situations where it is unclear if PTSD or the neurocognitive disorder is the primary diagnosis, and maybe what have been some of the more challenging cases and deciding between the two.
Yeah, if it's a mild TBI case, my lean is going to be that it's PTSD, right? If they're coming in with both, right? Unless I'm seeing them pretty acutely, right? So within like a couple weeks or a couple months after the head injury, right? There is some research that shows that in the acute stage, that if you've had a blast injury, you may have a little bit more processing speed difficulties and maybe some other mechanism injury. But again, they all go away after the acute phase. They may have a little bit more TBI, a PTSD than other mechanisms of injury. But again, if it's going to be a mild TBI, it's going to be my lean is going to be PTSD, right? When it gets more tricky is when it's going to be a moderate or severe TBI, right? And I don't have imaging, right? Either their imaging is clean, which can happen, right? Like their imaging could come out clean, even though like normal, even though they've had a moderate or severe TBI, right? And so I don't have as clear like indicator of what I expect in terms of my testing, right? So that can happen too. That being said, I think I would go by also by the level of impairment. I don't necessarily expect PTSD unless their PTSD is really, really debilitating. I don't expect the PTSD to make scores be very impaired, right? I think I expect that to depress some of the scores, but I don't necessarily expect them to be very impaired. So that's sometimes what I do. And sometimes we can't. Sometimes we're going to have to say, I think it could be this and this. And sometimes it's not mutually exclusive, right? And sometimes it's both. And I say it's both, right? And so my recommendations are going to be treat the PTSD and let's see what we have left, you know? Sometimes it's not going to be a clean answer, right? And sometimes it's not just one thing. Sometimes it's going to be 3, 4 things that are going to impact their cognition.
Thank you. And we have another clarification question. Can you clarify more what a T2 signal flare is on MRI imaging?
Okay. Yeah. So those are imaging. So it's kind of how the computers, how we analyze the scans that we get for, so the T2s, those are going to be MRIs, not CTs. So we're looking at, it's an MRI scan and it's looking at what type of images you're looking at. So a T1 is going to be looking at where the gray matter looks darker than and the white matter looks lighter. A T2 is going to be when the gray matter looks lighter and the white matter looks darker. And so it's kind of looking at like what you're looking at. Like T1 is better at looking at structure. T2 is better at looking at like lesions and abnormalities. So depending on what you're looking for, that's what you're going to kind of look at. So for this guy, I believe they were looking at T2s, right? And because the T2 is going to be what shows up, what shows the abnormalities and the lesions, so that hyperintensity. So that's what the T2 is.
Thank you. And then a question, since TESS uses both hands, non-dominant and dominant hands, have you seen significant impacts of ambidextrous people on the results of the tests?
Not a lot. Handedness doesn't necessarily impact laterality as often as people might think. Like there are a percentage of left-handers where brain may be organized differently, where it's not going to be language left, like visual spatial right, but it's not a huge percentage. So for a lot of folks, I can guess that it's going to be like as I expect a right-handed person to be. That being said, I'm going to have to keep that in mind, right? I'm going to have to keep that in mind and feel like, especially if I have imaging that shows that I should expect one thing and my tests are showing something different, then I may have to consider the possibility that the brain is not organized the way I would expect, and that may be coming into play too. So, and that just again complicates the picture again.
Well, it looks like that's it for our questions. Just wanted to thank you again for your time, Dr. Kim. We greatly appreciate it and very informative. And also just a quick announcement, just everyone in the meeting. If you didn't see in the chat, the video will be posted on the Division 19 website, and you can find the link in the chat.
Thank you, everyone. Have a good night.
Thank you, Dr. Kim.